Hello, okay lang po ba yung yung view po?
Yes, you may make it larger also. I-present mo na lang.
Okay, good afternoon everyone. Praise be Jesus and Mary.
Now and forever.
Okay po, let's start. My report for today is all about hypertension. May brief intro po ba tayo? Sino po yung pwede makapag-define ng hypertension po dyan sa mga mas nakakaalala pa? Hello? You may answer po. Feel free po. Kita.
Um, Good afternoon.
Yes po. Yes po, Ma'am Janine.
So, hypertension, or commonly known as high blood pressure, is when your blood pressure levels are increased.
Okay, thank you po, Ma'am Janine. So, that's it po sa sa hypertension na definition po. Um, as we start our lesson for today, these are the learning outcomes po ng report na prepare ko. At the end of this session, we will be able to distinguish the significance and applications of pharmacology in the practice of pharmacy. We will be able to explain the mechanisms of blood pressure control and pathophysiology of hypertension, identify blood pressure categories, and describe the pharmacokinetic properties, mechanisms of action, clinical applications, and pharmacologic and toxic effects of different antihypertensive drug class. So hypertension, as we all know, it is also known as high or raised blood pressure and is a condition in which the blood vessels have persistently raised pressure. So, ito po yung mga classification ng hypertension basis of blood pressure. Meron po tayong normal, pre-hypertension or elevated, stage 1 hypertension, stage 2 hypertension, and hypertensive crisis. Y- Yan po, nagmo-move po siya, yung slides, nag-move na po.
Yes, ma'am. Okay na.
Sige, ganyan, ganyan ko na lang po. So, meron po tayong tinatawag na hypertensive crisis. Ang hypertensive crisis po ay may hypertensive urgency at hypertensive emergency. Hypertensive urgency or asymptomatic severely elevated blood pressure ay acute and severe rise in BP without impending end organ damage. Habang ang hypertensive emergency naman po ay yung acute and severe rise in BP, but ang pinagkaiba lang po nila is meron siyang with impending end organ damage. Uncontrolled elevated blood pressure may lead to risk of end organ damage, especially the kidneys, heart, and brain. So risk factors, what are the risk factors? A family history of a cardiovascular disease, smoking, and metabolic syndrome including obesity, dyslipidemia, and diabetes. So, we have two types of hypertension, the essential or the primary hypertension and the secondary hypertension po. Essential hypertension is hypertension with no specific cause. Habang ang secondary hypertension naman is hypertension with a specific etiology. So, eto po, may nilagay po akong mga examples. Causes of hypertension sa secondary occurs quickly and more severely. Maybe dahil may obstructive sleep apnea, heart defects, kidney disease, medication or illegal drugs, adrenal or thyroid conditions. So, meron tayong mga contributors to development of hypertension according sa mga epidemiologic evidence. Ang mga contributors po na ito ay yung mga genetic factors, psychological stress, environmental factors, at saka mga dietary factors. Nagde-develop siya over time kaya dun siya nagre-result most of the time sa primary or sa essential hypertension. Okay lang po ba? Naririnig po ba ako?
Yes, ma'am. You may go on.
Thank you. So, the normal regulation of blood pressure is equal to cardiac output times peripheral vascular resistance. So, at least na-refresh na po tayo, no? Kasi, um, ako, upon doing my report, akala ko alam ko na to pero nakalimutan ko na pala yung iba. Tama yung sabi ng classmate natin kanina na nagpa-enroll siya ng masters kasi para ma-refresh yung memory kasi nangangalawang ng mga utak natin. Kaya good job po, sir. So, nandito na po tayo sa the four anatomic control sites for blood pressure maintenance or regulation. So, meron tayong mga control sites para ma-regulate ang ating blood pressure. Number one is the arteriole. Number two is the post-capillary venules. Okay lang po ba yung diagram? Mas nasusundan naman po. Number three is the heart. And number four is the kidney. Other BP control mechanisms are the baroreflexes. It is mediated by the autonomic nerves. And the humoral mechanisms by the renin-angiotensin-aldosterone system. Local release of vasoactive substances from the vascular endothelium helps regulate the vascular resistance. Example po ay vasoactive substances like endothelin-1 which causes vasoconstriction while nitric oxide causes vasodilation. So, eto po, may nilagay po akong image ng postural baroreflexes. So, baroreflexes is responsible for the rapid moment-to-moment adjustment in the blood pressure. Example po nito is yung pag-transition from reclining to upright posture po. So, carotid and aortic baroreceptors. They are stimulated by the stretch of the blood vessel walls due to the internal arterial blood pressure. Baroreceptors, baro means pressure or stretch. It can detect arterial pressure reduction from pooling of blood in the veins below the level of the heart during transition to upright position. Yung pag-transition po. This leads to an increase in the sympathetic outflow. Na-activate po yung alpha or yung mga beta receptors through nerve endings to increase the vasoconstriction and cardiac output to restore normal blood pressure. So ito po yung renal response para mag-decrease yung blood pressure. The kidney is primarily responsible for the long-term blood pressure control through regulating blood volume. A reduction in renal perfusion pressure leads to intrarenal blood flow redistribution and increased reabsorption of salt and water. So decreased pressure in renal arterioles and sympathetic neural activity via beta adrenoceptors. The renin and angiotensin II production, activation of the RAS. So angiotensin II, ito po, is a vasoactive peptide that causes direct vasoconstriction, meaning nagnanarrow po ang blood vessels na makaka-increase ng BP. Stimulation of aldosterone synthesis in the adrenal cortex. Aldosterone is a mineral corticoid which increases renal sodium absorption and intravascular blood volume, which increases the BP. So, ito po yun. Masyado kong mabilis. Tapos na po. So, ito po yung na-familiar naman ho tayong lahat kung ano ito. Ito po yung nephron. So, andito po tayo ngayon sa first category or first drug class for the hypertension po, which is or which are the diuretics. So, I'm showing you the nephron. Nakita na naman po natin si nephron. So, ito po, as we all know, familiar na po tayo sa structure po ng nephron na nakikita sa ating kidneys. So, the first diuretic class that I will discuss is the carbonic anhydrase inhibitors. Saan po ba ang site of action ng mga carbonic anhydrase inhibitor po sa mga nakakaalala? Feel free po. Hello? Yes po, Ma'am Mary Sade.
Sa, if I'm not mistaken, simultubule.
Yes po, thank you po, Ma'am Mary. Carbonic anhydrase inhibitor is located po, yung site of action niya is sa PCT or dito po sa proximal convoluted tubule. The mechanism of action inhibits carbonic anhydrase enzyme which blocks sodium bicarbonate reabsorption. So, kapag na-inhibit po ng carbonic anhydrase enzyme na which blocks the sodium bicarbonate reabsorption, ang effect niya po ay nag-reduce ang reabsorption of carbonic acid. Kapag nag-reduce na po yun, it will lead to self-limited diuresis. And it can cause metabolic acidosis, meaning po is reduced body pH. So, ang clinical application po ay urinary alkalization, pwede po siya sa metabolic alkalosis, acute mountain sickness, and glaucoma. It will reduce the aqueous humor to decrease intraocular pressure. So, ano po ba yung mga toxicities ng carbonic anhydrase inhibitors or different interaction. Hyperchloremic metabolic acidosis po. Puwede din po siya sa yung nagkaka-toxicity yung mga renal stones, renal potassium wasting, and hypophosphatemia. Nagko-cause rin po siya ng drowsiness and hypersensitivity reaction. Contraindicated po siya sa may cirrhosis dahil magko-cause siya ng hyperammonemia and hepatic encephalopathy. Ano nga po yung yung example ng carbonic anhydrase inhibitor ng mga drugs under po dito if wala, interaction lang natin. If may nakakaalala pa po. Wait, wait, wait. Yes po, Ma'am Sade.
May mga amides. I forgot the brand name po, yung mga amides.
Yes po, thank you po. It's like acetazolamide, na mga brenzolamide, dorzolamide. Um, yun pong brenzolamide, usually ginagamit siya sa glaucoma. Yan po. So, ang next po na i-discuss ko is ang loop diuretic. Um, sino po ang nakakaalala kung saan ang site of action niya? Ang site of action po ng loop diuretics is dito po sa ascending loop of Henle. Sa ascending loop of Henle po. Mechanism of action is ini-inhibit niya po ang sodium chloride reabsorption in the ascending limb of loop Henle. Diyan na po ang mechanism of action niya. Diyan rin po nagte-take ng action. So, ano po ang effect? A marked increase in sodium chloride excretion. Marked increase, kaya po tinatawag siya minsan, it is referred to as the high ceiling diuretics. Ang mga loop diuretics. So, clinical application is for acute pulmonary edema and other edematous conditions. Hyperkalemia, kasi it significantly enhances urinary excretion. Acute renal failure, it increases the rate of urine flow and potassium excretion. An ion overdose, kasi it serves as a treatment of toxic ingestions po, like the bromide, fluoride, and the iodide. So, toxicities of or interactions, hypokalemic metabolic alkalosis, hyperuricemia, because it will it will maybe lead to gout, hypercalciuria, leading to mild hypocalcemia and secondary hyperparathyroidism. Hypomagnesemia or magnesium depletion and hypovolemia. Toxicity may also cause ototoxicity. Those related ang hearing loss. It may worsen with aminoglycoside antibiotics, allergic reactions, and it is contraindicated for those with sulfonamide hypersensitivity and patients with hepatic cirrhosis, heart failure, and borderline renal failure. So, examples of the loop diuretics are, sino pong may nakakaalala? Loop diuretics, yes po. Cervergel, furosemide, effervescinic acid. Wow, memorize talaga ni Sir. Sana all. So, yes po, tama po. Meron po tayong example na sulfonamide loop agents. Under po doon si furosemide, bumetanide, and torsemide. Meron din po tayong phenoxyacetic acid derivative. Diyan po belong yung ithracinic acid. So, next is the thiazides. Ang site of action po ng thiazides, if may nakaka-remember po. Ang site of action po ng thiazide is distal convoluted tubule, sa DCT po siya. Ang mechanism of action niya ay ini-inhibit niya po ang sodium chloride na reabsorption. Kapag na-inhibit po ang sodium chloride reabsorption o ang sodium chloride cotransporter NCC, ang effect po ay modest increase in sodium chloride excretion. So, ang clinical application po is hypertension, heart failure, nephrolithiasis due to idiopathic hypercalciuria. Yun pong idiopathic hypercalciuria, ang ibig po niya sabihin is yung example po, may kidney stones ka na nagko-contain po ng calcium. Tapos pag hindi po siya naagapan, nagiging nephrolithiasis po siya. Nephrolithiasis po is ano rin po siya, isang form ng kidney stones pero yung mas worse na condition, pwede po gamitan siya ng thiazide. Nephrogenic diabetes insipidus. Toxicities or interaction po ng thiazides, it may cause hypokalemic metabolic alkalosis. Katulad po ng loop diuretics. Impaired carbohydrate tolerance. Meaning po, nagkakaroon ng hyperglycemia due to the stimulation of ATP potassium channels, and it can cause hyperpolarization of beta cells, leading to insulin release inhibition. Nag-exacerbate po siya na ang hypokalemia, hindi po hypo po. Toxicity also may lead to hyperlipidemia, increase in total serum cholesterol and LDL. Hyponatremia due to hypovolemia and increased thirst. It may impair uric acid metabolism and gout. Allergic reactions, weakness, paresthesias, impotence, acute angle closure glaucoma, and contraindicated also in hepatic cirrhosis and borderline renal failure. Examples of thiazides are hydrochlorothiazide, the HCTZ, chlorothiazide, indapamide, metolazone, and chlorthalidone. Next is the potassium-sparing diuretic. Site of action is the collecting tubule. Mechanism of action, it blocks the mineral corticoid receptors. Competitive aldosterone antagonist. It inhibits the sodium influx through ion channels in the luminal membrane via epithelial sodium channel or yung tinatawag po nating INAC. So, ang effect niya po is it reduces sodium absorption in the collecting tubules and ducts. Less sodium retention, but also less po ang potassium wasting. Since potassium sparing po siya. Clinical application, excess mineral corticoid or hyperaldosteronism. Yung primary po ay nagkakos po ng Conn's syndrome. Secondary is evoked by the heart failure, hepatic cirrhosis, and nephrotic syndrome. Liddle syndrome, isa rin po siya sa clinical application po. What is this syndrome? It is a syndrome or rare autosomal disorder causing activation of the sodium channels. Amiloride is useful also for this condition. And another clinical application is lithium-induced nephrogenic diabetes insipidus. Amiloride is also useful for this condition. Toxicity or interaction po ng potassium-sparing diuretics are the hyperkalemia, hyperchloremic metabolic acidosis, acute renal failure, kidney stones, and it is contraindicated with agents that also causes hyperkalemia. These agents are oral potassium, some beta blockers, some ACE inhibitors, and ARBs. Examples of the potassium-sparing diuretics are the aldosterone antagonist, the most popular one, the spironolactone, and eplerenone. And we have the epithelial sodium channel, the ENaC inhibitors, like amiloride and triamterene. Next is the osmotic diuretic. They are somehow called aquaretics. Site of action, the PCT, proximal convoluted tubule, descending limb of the loop of Henle, and the collecting tubules. The mechanism of action, physical osmotic effect on tissue water distribution, since it is retained in vascular compartment. Usually accompanied po siya ng initial na hyponatremia, then followed by hypernatremia. Wait, mommy's at school. Sorry po. Continue po ako. Yung effect po ng mga osmotic diuretic, the presence of non-reabsorbable solute prevents the normal absorption of water by interposing a countervailing osmotic force. Meaning, natriuresis is of lesser magnitude than the water diuresis, leading eventually to excessive water loss and hypernatremia. Yung clinical application po niya is nakaka-reduce po siya ng intracranial pressure and intraocular pressure given IV. For conditions where there is increased solute load such as rhabdomyolysis, chemotherapy, and also glaucoma. Toxicities or interaction, extracellular volume expansion prior to diuresis. Dehydration, hyperkalemia, hypernatremia. For hyponatremia also for patients with renal impairment. Acute renal failure. It is contraindicated in patients with renal insufficiency. Example po is ang mannitol. So, nandito na po tayo sa vasopressin, the ADH antagonist. Site of action, B1A and B2, yung antidiuretic hormone ADH receptors, V2 ADH receptors. So, mechanism of action, inhibition of vasopressin, ADH receptors in the collecting tubule. Effect, it reduces water reabsorption and increases plasma sodium concentration. So, yung clinical application po niya, pwede po siya sa may mga syndrome of inappropriate secretion, autosomal dominant polycystic kidney disease, and hyponatremia. Toxicities and or interaction, polyuria or nephrogenic diabetes insipidus, renal failure, dry mouth, thirst, hypotension, and hypernatremia. Tolvaptan and demeclocycline are contraindicated in patients with liver disease. Examples are conivaptan, tolvaptan, and the miscellaneous agents like democlocycline and lithium. So, here po na hinanap ko to sa sa internet. Gamit natin to no undergrad. Sinama ko na po siya dyan sa PowerPoint. Yung mga diuretics na uses and side effects niya po. So, next are the sympatholytic agents. So, there are four: the centrally acting sympathoplegic agents, sympathetic nerve terminal blockers, the alpha blockers, and the beta blockers. So, kapag sinabing centrally acting sympathoplegic agents, eto yun sila. May dalawa po. Ang alpha-2 agonists and the ganglionic blockers. Under po sa alpha-2 agonist ang clonidine methyl dopa, guanfacine guanabens, and under po sa ganglionic blockers ang the tetraethyl ammonium and hexamethonium melamine. So, alpha-2 agonist, yung site of action po niya is syempre po, sa alpha-2 receptors on presynaptic and postsynaptic adrenergic neurons. Yung yung na-discuss last time ni Ma'am na mga receptors ni na-discuss ni Ma'am Risa last meeting po na mga receptors. Alpha-2 agonists are generally alpha-2 agonists. Yung clonidine is considered lang po siya na partial agonist. Mechanism of action, it stimulates or activates central alpha-2 adrenoceptors which are GI-linked coupled receptors. It reduces central sympathetic outflow or reduce norepi release from noradrenergic nerve. Lower heart rate, cardiac output, and or PVR may decrease sympathetic tone. So, if decrease po ang sympathetic tone, increase po ang parasympathetic tone. So, pag increase po ang ating parasympathetic tone, nagde-decrease po ang ating BP. Clinical applications, hypertension. Methyl dopa is used in hypertension during pregnancy. It is called the gestational hypertension. Toxicities or interaction, postural or orthostatic hypotension may sometimes occur. Clonidine, more on sedation, dry mouth, depression, rebound hypertension with sudden withdrawal. Methyl dopa, sedation, nightmares, hemolytic anemia, vertigo, depression, lactation due to prolactin secretion. Potential na false positive COMS test. Yung example is ito po, yung clonidine methyl dopa, and the guanfacine guanabens. Next is the ganglionic blocker. Ang site of action po niya is dun sa mga nicotinic receptor po. Mechanism of action, it completely blocks the acetylcholine at the nicotinic cholineceptors on the postganglionic neurons in both sympathetic and parasympathetic ganglia. Ang effect po niya ay non-selective blockade of autonomic outflow. Non-selective blockade of autonomic outflow. Clinical application, it is no longer used clinically due to intolerable toxicities. So these toxicities or interactions are sympathoplegia, meaning excessive orthostatic hypotension, tachycardia, tachycardia and sexual dysfunction. It also causes sedation, tremors, pupillary dilation, and or constriction. Parasympathoplegia, inhibited GI secretion and peristalsis, constipation, urinary retention, glaucoma, blurred vision, dry mouth. So examples are tetraethylammonium and hexamethoniumecamilamine. So next is ito po sila. Ang sympathetic nerve terminal blockers. Site of action po ng mga sympathetic nerve terminal blockers is the vesicular membrane, associated transporter or the vesicular monoamine transporter, the VMAT. Makikita rin po sila sa VAMPs or the vesicle associated membrane proteins and the synaptosome associated proteins, the VAMPs and the SNAPs, and the VMAT. Mechanism of action, it blocks the VMAT and deplete the catecholamine stores. It also inhibit the VAMPs and the SNAPs. Interfere with vesicle membrane fusion and catecholamine release. Sympathetic effects, it inhibits the VAMPs and SNAPs, interfere with the vesicle membrane fusion and catecholamine release. Yan po yung yung effect ng mechanism of action ng mga sympathetic nerve terminal blockers. Yung effect niya po is it may prevent normal release of norepi from the postganglionic sympathetic neurons. Sa postganglionic na sympathetic neurons po, it may prevent the normal release of norepi. And it may reduce all the sympathetic effects, especially cardiovascular, meaning it will decrease the BP. Toxicities or interaction on the recipients, it may cause sedation, psychiatric depression, GI disturbance, Parkinsonism symptoms due to dopamine depletion. The guanethidine and guanadrel, severe orthostatic hypotension, sexual dysfunction, increased GI motility, and diarrhea. So, these are the examples, the reserpine, guanethidine, guanadrel, beryllium, bethanidine, and debrisocin. Next are the alpha blockers. So, yung alpha blockers, meron po siyang non-selective and alpha 1 blockers po. So, yung mga non-selective na alpha blockers, ito po sila si phenoxybenzamine at saka si phentolamine. Yung site of action po ng alpha blockers, yun po, alpha 1 and alpha 2. Mechanism of action, they are non-selective blockade of alpha 1 and alpha 2 receptors. Effects, it lowers the BP through blockade of alpha-mediated vasoconstriction, increased heart rate due to the baroreflex activation. So, ang clinical applications po ay for pheochromocytoma. Pheochromocytoma is ano po yung tumor po of the adrenal medulla or sympathetic ganglion cells, which secretes the excess norepi and the epi. Toxicities or interactions ng mga alpha blockers, nagkakos po sila ng orthostatic hypotension, tachycardia, myocardial ischemia. Tapos yan po ang example natin ng phenoxybenzamine at saka ang phentolamine. So, ang alpha 1 blockers like prazosin, terazosin, and doxazine, yung site of action, syempre po is sa alpha 1 receptors. The mechanism of action, it selectively blocks the alpha 1 receptors in the arterioles and the venules. Ang effect niya po ay nakaka-lower po siya ng BP by preventing the sympathetic vasoconstriction, reduce the prostatic smooth muscle tone. Clinical application is for hypertension and benign prostatic hyperplasia, the BPH. The zosins, yung mga zosin po natin, ay nag-i-improve po ng urine flow via partial reversal of smooth muscle contraction in the enlarged prostate po. Kaya po siya nagagamit para sa may mga sa BPH. Toxicities or interactions, first dose orthostatic hypotension. So, sa beta blockers po, meron po tayong non-selective beta blockers, beta 1 blockers, beta blockers with intrinsic sympathomimetic effect, partial agonist siya. And beta blockers with alpha 1 blocking effects. May isa pa, beta blockers with local anesthetic action or membrane stabilizing effect. Add ko na lang later po. So, ang pinakauna is ang non-selective beta blockers. Ang site of action po nila ay sa beta 1 and beta 2. Mechanism of action is non-selective beta 1 and beta 2 adrenoceptor blockade. Effects, negative inotropic effect. Negative inotropic, syempre, sa lahat na po siya sa heart. Decreased force of contraction and decreased heart rate, prevents sympathetic cardiac stimulation, lower heart rate and BP, and then it reduces the renin secretion. Clinical applications of the non-selective beta blockers, hypertension, angina pectoris, arrhythmias, heart failure, coronary disease, migraine, hyperthyroidism, and glaucoma. Toxicities or interactions, bradycardia, worsened asthma due to the beta 2 blockade in bronchial smooth muscles, causing the increased airway resistance, fatigue, vivid dreams, and cold hands. It can impair recovery from hypoglycemia. So we must use this with caution in insulin dependent diabetic patients. It may also increase VLDL and decrease the cholesterol. Examples of the beta blockers, mga olol po natin, na pranolol, cartiolol, carvedilol, labetalol, ano pa, nadolol, timolol, basta yung mga lol. And also, yun po, yung mga lol. Beta 1 blockers, site of action, beta 1 receptors. Mechanism of action or the selective beta 1 blockade. Effects, it prevents sympathetic cardiac stimulation. So, if it will prevent the sympathetic cardiac stimulation, it will may result to lower heart rate and BP. Clinical applications, angina pectoris, hypertension, arrhythmias, and glaucoma. Toxicities or interaction, it may cause bradycardia, fatigue, vivid dreams, and cold hands. So example of beta 1 blockers are the metoprolol, atenolol, acebutolol, betaxolol, esmolol. Esmolol is the one with the shortest half-life. Next are the beta blockers with intrinsic sympathomimetic effect, the partial agonists. Site of actions are the beta 1 and beta 2. Mechanism of action is partial lang po siya, partial agonist or stimulation of beta 1 and 2 receptors. Effects, it lowers the BP with modest lowering of heart rate only. Clinical application is for hypertension, arrhythmias, and migraine. Toxicities or interaction may cause fatigue, the same po, vivid dreams, and cold hands. Mostly, ang example po nitong mga beta blockers with intrinsic, yung mga partial agonist, yung pindolol, penbitolol, bopendolol, at yung mga celeprolol, mga ano, medyo bago siya sa pandinig ko, yung mga cartiolol, yung ganun, oxprenolol, mga ganyan. Next po is the beta blockers with alpha 1 blocking effects. Beta blockers po siya na may alpha 1 blocking effects. Yung mga example nito is yung carvedilol, yun po sila, labetalol, bucindolol. Yung site of action po nila ay sa beta at saka alpha. Mechanism of action, they blocks both beta and alpha 1 receptors. The effect, they antagonize action of the catecholamines on beta 1, beta 2, and alpha 1 adrenergic receptors. Its clinical application is mainly for heart failure. Toxicity, it may cause fatigue. Meron pa pong isa, i-a-add ko lang po later sa PowerPoint ko, i-edit ko po. Mga beta blockers with local anesthetic action or the membrane stabilizing effects. Their site of action po is the beta receptors and the sodium channels. Yung mechanism of action nila is local anesthetic effect due to the blockade of sodium channels. So, yung effect po niya is parang may local anesthesia. Clinical applications, it must not be used topically in the eyes since the local anesthesia of the cornea may prevent protective eye reflexes. Toxicities, it prevent detection and protective eye reflexes for foreign particles that may enter the eye. So, examples of these beta blockers with local anesthetic action are the acebutolol, labetalol, and metoprolol. Sila po. So, tapos na po tayo sa mga beta blockers. Next po are the calcium channel blockers. Pero bago po yan, para mawala po yung antok natin, may ano po ako, may review question po na ano nga, may sound, may nakakalala po kanina. Ano nga po yung ano normal blood pressure po natin sa adult? Yes po. Correct po, Ma'am Janine. Thank you po. And um, what is the diuretic subclass po of acetazolamide? Sa mga may nakakaalala po. Yes po, thank you Ma'am Jaira. It is a carbonic anhydrase inhibitor. Pampawala lang po ng antok natin. So, eto na po tayo sa continuation ng ating antihypertensive agent. Meron na po ang kulang na lang po natin are the calcium channel blockers, the vasodilators, and the angiotensin antagonists. So, naglagay po ako dito ng ano table ng calcium channel blockers. Ito po na may dihydropyridines. Dito rin po yung mga examples, mga dipin-dipin, amlo, nicardipine, nifedipine, fellow, yan po sila. Site of action is a voltage-gated L-type calcium channel. Ito po yung mechanism of action, inhibition of calcium influx into the arterial smooth muscle cells. It blocks the vascular calcium channels more than the cardiac calcium channels. So ito po ang effect niya, reduction of peripheral vascular resistance. So nagkakaroon tayo ng vasodilation. Then it lowers the blood pressure. Dihydropyridines are more selective as vasodilators and have less cardiac depressant effect than non-dihydropyridines. So, clinical application, prophylaxis siya ng hypertension, angina pectoris, and arrhythmias. Sa Raynaud's syndrome, a phenomenon, a condition that causes discoloration or decreased blood flow, usually to fingers, tsaka sa toes, due to the blood vessel spasms in response to cold, stress, or emotional upset. So, dito nagagamit si felodipine at saka si nifedipine. Toxicities or interaction, hypotension, and baroreceptor reflex induced tachycardia. It may cause cardiac depression. Minor side effects are flushing, dizziness, nausea, constipation, and peripheral edema. So, yan po yung mga dipin-dipin. Ang non-dihydrodipines calcium channel blockers are the verapamil. It has the greatest cardiac depressant effect. Next is the diltiazem. Intermediate ang kanyang action. So, ito po yung site of action. Ang MOA niya po, ang effect, yung site of action niya po ay voltage-gated L-type channel, calcium channels rin po. It is non-selective block of L-type calcium channels in the vessels and heart. It blocks the cardiac ang diltiazem naman po, binablock niya ang cardiac calcium channels more than the vascular calcium channels. Reduces calcium-dependent action potentials and impulse generation in the SA and AV nodes of the heart. So, it decreases heart rate and cardiac output aside from vasodilating niya na effect. So, reduce ang vascular resistance, lower ang BP. Prophylaxis siya sa hypertension, angina pectoris, arrhythmias po. Ang diltiazem naman sa Raynaud's phenomenon. Next are the vasodilators. Meron po tayong dalawang class sa vasodilator, ang oral po at saka ang parenteral agents. So these are the oral vasodilators. Example is the hydralazine, minoxidil, and the diazoxide. Diazoxide is an injectable also available but mostly oral ang nagagamit natin sa kanya. Site of action is sa smooth muscles of arterioles. Yung MOA niya po ng hydralazine, it releases the nitric oxide from drug na endothelium. Minoxidil naman and diazoxide causes of hyperpolarization of cell membranes through opening of potassium channels. Yung effect, nagre-relax po siya ng smooth muscles sa arterioles and nagde-decrease ang systemic vascular resistance. Ang clinical application is for hypertension and heart failure. Ang toxicity po ng hydralazine, headache, ito po, nausea, anorexia, palpitation. Yung minoxidil naman po, headache, sweating, and yung very popular hypertrichosis. Nagkakaroon ng hair growth. Sa diazoxide, hyperglycemia, excessive hypotension, especially when parenterally administered. Yun po yung mga oral na vasodilators. Meron po tayong parenteral vasodilators. Example is nitroprusside or the sodium nitroprusside. Yung action niya po is a smooth muscle of arterioles and veins. Nitroprusside releases nitric oxide from drug or the endothelium. Releases of nitric oxide, nag-a-activate siya ng guanyl cyclase, causing the increased intracellular CGMP and vascular smooth muscle relaxation. So, kapag ganun po, nagdadilate po ang both arteries and veins, resulting to reduced PVR and venous return. So, nitrates and nitroprusside also relaxes the veins. These are the treatment of hypertensive emergencies. Yung nitroprusside, nag-accumulate siya ng cyanide causing metabolic acidosis, arrhythmias, and excessive hypotension. Sa ano po to siya na side sa kanyang toxicities or interactions. Antidote or prophylaxis of cyanide poisoning during infusion is sodium thiosulfate and hydroxycobalamin. Phenoldopam, another parenteral agent. Its site of action is the D1 dopamine 1 receptor. Phenoldopam is a D1 receptor agonist. It causes arteriolar dilation and natriuresis. Clinical application is for the treatment of hypertensive emergencies and post-operative hypertension. So, toxicity, phenoldopam may cause reflex tachycardia, headache, flushing, increased intraocular pressure, and must be avoided in glaucoma patient kasi nga nakaka-increase siya ng intraocular pressure. So next are our angiotensin antagonists. Ito po sila. May nilagay po akong figure dito po. Drugs acting on the renin-angiotensin-aldosterone system, ang RAAS po natin. So, meron po tayong groups dito ng renin inhibitor, the angiotensin converting enzyme, yung mga ACE po natin, yung mga nagtatapos sa ating mga pril. Meron din pa tayong angiotensin receptor blockers, yung mga sartan po natin. So, some channel blockers. So, ito po siya, yung RAAS po. Kung i-summarize ko po, reduced renal arterial pressure, sympathetic, neural stimulation, and reduced sodium delivery in the kidneys causes renin release from the kidney cortex. The renin converts angiotensinogen to angiotensin 1. Ito po, dito po tayo na nagsa-start sa may ibabaw po ng part. Angiotensin 1 is the inactive precursor decapeptide. So, angiotensin 1 is converted to the arterial vasoconstrictor octopeptide na tinatawag natin si angiotensin 2 by endothelial is the angiotensin converting enzyme. Angiotensin 2 also stimulates aldosterone release. Aldosterone causes sodium and water retention, which may also elevate the BP. Yan po yung summary po ng RAAS. So, angiotensin antagonist. Ito po. Ano po ba yung mga drug subclass na nasa angiotensin antagonist? So, meron pong renin inhibitor, the ACE inhibitors, the angiotensin receptor blockers, and the aldosterone antagonist. So, kapag sinabi pong renin inhibitor, ang example is the aliskiren. Ang site of action niya po ay sa renin. It inhibits the enzyme activity of the renin. Dito po siya banda. Ito po yung site of action niya, ang renin. Ito po yung renin inhibitor natin na si aliskiren. It inhibits the enzyme activity of the renin. Angiotensinogen will not be converted into angiotensin 1. Less angiotensin 1 means less angiotensin 2. So less angiotensin 2 means less aldosterone and it lowers the BP. So hypertension po ang clinical application niya talaga. Toxicity or interaction, hyperkalemia, renal impairment, potential teratogen din po siya. So, yung next natin is the angiotensin converting enzyme inhibitors, the ACE inhibitors. So, ang under po dito ang captopril, yung mga pril, enalapril, lisinopril. Lahat po sila ay mga prodrugs except lang sa ating enalaprilat dahil ang active form niya ay ang enalapril. ACE, as we all know, as peptide peptidase or kinase 2 or the plasma kinase. It inhibits the angiotensin converting enzyme, meaning it prevents the ACE from hydrolyzing angiotensin 1 to 2. So, dito po siya yung site of action niya. Ito po yung ACE inhibitors natin. Less ACE po means less ACE activity means less angiotensin. So it will reduce vasoconstriction and aldosterone secretion. Plasma kinase inhibition leads to less inactivation of bradykinin, a potent vasodilator. So principally, it will decrease the PVR. Its clinical application is hypertension and heart failure. Um, ACE is also useful in patients with diabetes and chronic kidney disease since they diminish proteinuria and they stabilize the renal function. So toxicity is for cough and angioedema due to the increase na bradykinin. Hyperkalemia, renal impairment, allergic skin rash, teratogenic, may interact with NSAIDs and impair hypotensive effects of ACE inhibitors by blocking the bradykinin mediated vasodilation, which is also mediated by the prostaglandin. So next is the angiotensin receptor number 3 blockers. Under dito yung mga sartans natin, valsartan, losartan. Site of action is the AT1 receptor. It blocks the angiotensin 2 type 1 receptor. Prevents angiotensin 2 from binding to target sites. So, kapag na-prevent, nagre-reduce ang vasoconstriction and aldosterone secretion. It does not increase the bradykinin. Clinical application is the same hypertension and heart failure. This is beneficial to patients na may heart failure and chronic na kidney disease. Adverse effects are similar to ACE inhibitors except that they are less likely to cause cough and angioedema since they have no effect sa bradykinin metabolism. Next are the aldosterone antagonists. Ito po, number 4, aldosterone antagonist. They are the spironolactone and the eplerenone. Ito po yung site of action nila. Dito po. Sa aldosterone receptors. They block the aldosterone receptors at the renal collecting tubules. Kapag na-block yan, nag-i-inhibit ng aldosterone. Inhibiting the aldosterone binding results to reduction of sodium absorption in the collecting tubules and ducts. So, less yung ano po, yung sodium retention, pero less rin ho yung potassium wasting niya since mga spironolactone, eplerenone are our potassium sparing diuretics. Then, its toxicity is hyperkalemia, yung mga interaction niya, hyperchloramic metabolic acidosis. Aldosterone antagonist activity may be inhibited by NSAIDs since efficacy depends on the renal prostaglandin production. They are contraindicated with agents that also cause hyperkalemia, like oral potassium, some beta blockers, ACE inhibitors, and ARBs. So, yung may nakita ako sa internet yung ano natin noon sa undergrad, yung Katsung book natin. Meron siyang summary, nilagay ko na rin yun po. Ewan ko pa kung mababasa niyo, but isa-send ko po tong PowerPoint ko sa inyo. Maganda kasi siya kasi naka-summarize siya may, na drugs used in hypertension. Naka-table po. Ito po. Yan po yung summary ng lahat po sa hypertension. Ise-send ko na lang po ay sa GCR natin or sa group chat. But ano, 'yan tapos na po ako sa hypertension pero meron pa po tayong heart failure. I hope you are still with me, guys.
Go, ma'am.
So, heto na po tayo sa heart failure. Asan na? Heart failure. Heart failure. Ay, ito. Heart failure. Ay, naklik na din. Heart failure po. Pagkatapos ng hypertension, nandito na tayo sa heart failure, guys. Laban pa ba ang all? So, heart failure is a progressive disease characterized by a gradual reduction in cardiac performance. So, yan po yung proper na definition po ng heart failure. So, types of heart failure. May tatlong types po ang heart failure natin. Um, left-sided heart failure. Meron po tayong right-sided heart failure at the congestive heart failure. Nawala na siya sa isip ko nung gumagawa ako ng PowerPoint. Kasi akala nakalimutan ko na marami palang types of heart failure. Good thing na nag-report tayo at least na-refresh ako na, uy, ang dami ko na palang nakalimutan. Sana hindi lang ako. So, let's start sa left-sided heart failure. So, left-sided heart failure, meron siyang dalawang type. The systolic failure or heart failure with reduced ejection fraction. At saka yung diastolic na heart failure. Kapag yung systolic na failure, yung left ventricle loses normal contracting ability. Yan yung sa systolic. Sa diastolic naman na heart failure with preserved ejection fraction. Yung isa na reduced, yung isa naman is na preserved. Yung left ventricle po ng diastolic is hindi siya nakaka-relax normally. The heart cannot properly fill with blood during resting period between each beat. Usually, kasi yung heart niya is yung stiff na yung muscles. Yan po yung sa diastolic. Tapos, meron po tayong right-sided heart failure, also known as the right ventricular heart failure. Usually, as a result po siya ng left-sided failure. So, kapag may heart failure na may sa left po, automatically meron din po siya sa right-sided heart failure. Tapos last is the congestive heart failure or the CHF, stage where the fluid backs up into the lungs. So nagkakaroon siya ng pulmonary edema. And tissues, ang peripheral edema. So, ang pinagkaiba po ng systolic at saka diastolic heart failure, sa systolic, hindi na po siya nakaka-pump properly. Sa diastolic naman, hindi siya nakaka-feel properly. Systolic cannot pump properly ng blood, yung diastolic cannot feel properly ng blood po. So, ito po yung yung image niya po. Systolic dysfunction, may normal, tapos yun ang diastolic dysfunction. Systolic cannot pump properly po ng blood, diastolic cannot feel properly po ng blood. Kasi, yun nga po, kanina, hindi na siya nakaka-feel between each beat kasi yung yung muscles ng heart niya is very stiff na. So, primary signs and symptoms of all types of heart failure. So, ito po yung mga signs and symptoms ng lahat po ng uri ng heart failure po. Tachycardia, decreased exercise tolerance, shortness of breath, cardiomegaly, peripheral and pulmonary edema. Yung ba ah, so, pharmacology of drugs used in heart failure po. So, ano po ba yung goal natin dito? Yung treatment goal natin is to reduce the symptoms and slow the progression as much as possible during relatively stable periods, and manage acute episodes of decompensated failure. Positive inotropic drugs are helpful mainly in acute systolic failure. The cardiac glycosides are also reduce symptoms in chronic systolic heart failure. The ACE inhibitors, the ARBs, certain beta blockers, aldosterone receptor antagonists, and combined angiotensin receptor blocker therapy are the only agents in current use that actually prolong the life and reduce hospitalization in patients po na may mga chronic heart failure. These strategies are useful in both systolic and diastolic heart failure. So, ayon sa New York Heart Association scale, meron pong apat na class yung na failure po. Yung class 1 po, failure is associated with no limitation on ordinary activities and symptoms that occur only with greater than ordinary exercise. So, yung class 1, para lang ho siyang nakakatrabaho ka rin naman po yung patient. Wala talagang nagbabago sa daily activities niya, daily routines. Nagkakaroon lang siya ng symptoms kapag medyo nag-exert siya ng effort na greater than usual, greater than ordinary exercise niya. Sa class 2 naman is failure is characterized by slight limitation of activities and results in fatigue and palpitations with ordinary physical activities. So, itong class 2 is kapag medyo sumobra ka, magkaka-fatigue ka na, may palpitation nalilimit talaga, may slight limitation. So, sa class 3 failure, results in fatigue, shortness of breath, tachycardia, with less than ordinary physical activity, but no symptoms at rest. Class 4 failure is associated with symptoms even when the patient is at rest. So, yun po siya. Then, summary of drugs used in heart failure. So, ito po yung mga drugs na familiar tayo sa mga patients na may mga heart failure. So, table po yung nilagay ko. Meron po tayong cardiac glycosides like the digoxin. Ito po. Sodium potassium ATPase inhibition results in reduced calcium expulsion and increased calcium stores in the sarcoplasmic reticulum, meaning meron po siyang positive inotropic effect. So, ang effect niya ay increased cardiac contractility but with cardiac parasympathomimetic effect. It slowed sinus heart rate and slowed atrioventricular conduction. So, yung clinical application niya naman po ay chronic symptomatic heart failure, rapid ventricular rate in arterial fibrillation. Pharmacokinetics, toxicities, and interaction, magkakaroon po ng nausea, vomiting, diarrhea, cardiac arrhythmias, yun po hallucination, visual disturbances, aberration of colors, and perception. Nagkaka-hyperkalemia rin po. Hyperkalemia may reduce efficacy since potassium and digitals inhibit each other at the sodium-potassium pump, while hypokalemia may lead to toxicity. Hypercalcemia and hypomagnesemia increase the risk of digitalis induced arrhythmia. Tapos yung next is yung beta agonist na mga dobutamine and dopamine po. Next is the beta agonist. Nandito rin po yung piperidine, natriuretic peptide, and the neprilysin inhibitor. So, maganda po to kasi naka-table na siya. Hindi na po tayo mahihirapan pa. So, sa dobutamine, beta selective beta 1 selective agonist which increases the CAMP synthesis. It increases cardiac contractility and output and decreases ventricular filling pressure. Clinical application is for acute decompensated heart failure. For both tachycardia, arrhythmias, additive interaction with sympathomimetics. We have also the dopamine receptor agonists where in higher doses activate beta and alpha receptors. Increases renal blood flow, meaning higher doses increases cardiac force and blood pressure. Acute decompensated heart failure and shock. Next is the piperidine. Under the piperidine is the milrinone. So it also possesses the positive inotropic effect. eh, Phosphodiesterase type 3 inhibitor which decreases the CAMP breakdown. Vasodilation, it decreases the PVR, increase cardiac contractility. Clinical application is for acute decompensated heart failure. Piperidines, specifically the milrinones, um, its pharmacokinetic and interaction arrhythmias additive with other arrhythmogenic agents. So, a different natriuretic peptide is the nasiretide. It activates the brain natriuretic peptide receptors and it increases the CGMP. Effect is vasodilation. It is for the acute decompensated heart failure. So, it may cause renal damage and hypotension. Last is the neprilysin inhibitor, mainly the sacubitril. It inhibits the neprilysin and reduces breakdown of ANP, the atrial natriuretic peptide, and BNP, brain natriuretic peptide. It is it has the vasodilation effect. Clinical applications used only in combination with valsartan for chronic heart failure. Its pharmacokinetic, toxicity, and other interaction may cause hypotension and edema. Also, for heart failure, we have the vasodilators, the beta blockers, and the diuretics and the angiotensin antagonist. But hindi ko na po siya nilagay dyan kasi nandun na siya sa previous slides po. So, I think that's the last one. Ang hirap pala magsalita. Thank you
Okay.
guys.
Ma'am Jessa, may you may unshare your PowerPoint presentation now. I hope I am audible. Medyo maingay dito sa amin. I'm currently in our house. But anyway, that's for hypertension and heart failure. Pinagsama ko sila since they have similarities in terms of drugs na ginagamit natin. Well, except for like positive inotropic drugs like digoxin na ginagamit natin for heart failure. But the rest that are not really inotropic agents are the mainstays for both our heart failure and our hypertension. So that was just a sort of a review, a refresher for all of us. Though we had this one in our undergraduate na study, but let's just have a review and then I'll be sharing with you this algorithm na ginagamit natin when we decide what we're going to do with our patient with hypertension or with with heart failure. But these algorithms depende pa. Yung mga case studies na binigay ko sa inyo, you may use this algorithm but syempre we have to assess the patient if the patient fits in the algorithm na gagamitin ninyo. Let me start first. Wait lang. Let me start with... Saan na yun? I-open ko muna ha. This one. This is for the heart failure. So, you may utilize this one also. Share ko ng screen ha. I hope makita nyo siya. Saan na yun? Wait lang, nawala. Ayan. Okay. Makita mo? Ayan. Pwede natin itong gamitin. We have here the JNC8 hypertension guideline algorithm. So ito yung mga initial drugs. So hindi na ako mag-isa-isa sa kanila ha since that these are all being reported already. So we have here initial drugs of choice for our hypertension. We have the ACE inhibitors, the ARBs, the thiazide diuretics, and the calcium channel blockers. So this algorithm is used for adults aged 18 years and above with hypertension. So please take note here, number one, before we decide what medication are we going to give, implement lifestyle modification. And in this guideline, there will be setting of the BP or the blood pressure goals for our patient. So nahati ito sa dalawa. We have here the general population, and this means the patient has no diabetes or has no chronic kidney failure. On the other side, yung naka-red naman, if merong concomitant diabetes or CKD yung ating patient. Let's focus first on our general population. The blood pressure goal is dependent on the age of the patient. If the patient is more than or equal to 60 years old, ang BP goal natin is less than 150/90. Kung less than 60 years old, kung bata-bata pa yung ating patient, the goal is less than 140/90. Okay, so that's the first thing. We have our goals here. For patients with concomitant diseases like diabetes and CKD, this is true for all ages and races. The BP goal is the same lang. It's less than 140/90. Okay? So again, kung may concomitant na disease, the same lang yung goal natin for the blood pressure, whether they have CKD or they have diabetes or not, or if ano yung race nila. Okay? So diretso na siya agad. Initiate ACE inhibitor or ARBs. Pwedeng alone or pwedeng in combination with another class of drugs. So you may look at this initial drugs of choice for our hypertension kung gustong mag-combine. But for those sa general population, let's move on. Dito naka-divide yung depende sa race. So as Filipinos, syempre will be classified here sa non-black rheumatic. So we have here initiate thiazide, ACE inhibitor, ARBs or CCB, pwedeng alone or pwedeng in combination. And then we are going to assess. Kaya when I gave you the case studies, parating syempre may monitoring doon. So kung black naman, initiate thiazide or CCB, pwedeng alone or in combination. So if we achieve the blood pressure goal na nandito sa taas, just continue the treatment and just monitor the patient. If hindi, syempre, let's reinforce lifestyle and medication adherence, or we may titrate the medication to its maximum dose or we may consider addition of another medication. So it may be another ACE inhibitor, an ARBs, a CCB, or a thiazide diuretic. If na-meet ang goal, then continue. But if not, then the same thing. Reinforce lifestyle and medication adherence and add another class of drug. Okay? So these drugs are not actually mentioned here sa taas, the initial drugs of choice for our hypertension. So you may consider adding a beta blocker or an aldosterone antagonist and others na Ma'am Jessa had presented a while ago. And then we may titrate the medications dose to maximum. If na after that na-achieve yung ating blood pressure goal, then we may continue treatment. If not, eto, reinforce again lifestyle and adherence, and then again titrate medication to maximum dose and add another medication, or we may refer now the patient to a hypertension specialist kasi parang nabigay na natin lahat ng ating pwedeng ibigay here and hindi pa rin na-achieve ang goal. So, kailangan yan pagtuunan ng pansin ng isang hypertension specialist. So, yun yung ating yung guideline algorithm natin for our hypertension. So, again, in practice or yung mag-answer kayo ng mga case studies, you may refer to this guideline para doon sa ipopropose nyo na resolution for the patient with hypertension. Okay, so again, pwede niyo yan siyang gamitin. Saan na yun? Okay, sa baba, these are just, iniisa-isa lang yung drug classes, no, and then agents of choice, and then we have comments here. So under the comments, we may see things that we need to monitor. So just like if we give a patient diuretic, then we really have to monitor the electrolyte. So just like the potassium, kasi the patient may be prone to hypokalemia if given certain types of diuretics. And then in these guidelines, you may see also like hypertension plus concomitant diseases or conditions like heart failure, and then we have here our treatment of choice. So you may refer to this one also when we make decisions for our patient. Okay? So this is it for our hypertension. Do you have questions or like clarifications regarding this one? Wala. Wala, sure na. Now, how about sa ating, wait, let me check first. Heart failure. But before that, let's just have a review. No, I'll start with the stages first. Wait lang, ha. Mali yung napindot ko. Where's the stages? This one. Okay. In the stages. Okay, before we move on to the algorithm, let's have a little review on the stages of our heart failure. So, pag na-classify yung patient as stage A, the patient is at risk of having heart failure. Okay? So, there is no structural changes pa sa heart, but the patient may have conditions that would most likely cause heart failure. Okay, so just like yung may diabetes siya or the patient is obese, the patient may be at risk of heart failure. Pag nag-stage B na, then there will be structural heart disease already. So, meron ng possible signs and symptoms of heart failure. So, may mga changes na, especially in the heart. The heart may have enlargement. Okay? Pag stage C, ito na yung symptomatic talaga na heart failure. So, the patient with current or previous symptoms, signs and symptoms of heart failure na talaga. And then, pag nag-stage D, advanced heart failure, ito na yung stage wherein medyo nahihirapan na tayo with the treatment that we have. The patient may be unresponsive to the treatment and that the patient may require recurrent na hospitalization and then meron ng kailangan gawin sa heart, mga operations needed for the heart kasi hindi na kaya ng ating current na mga treatment. So that's the stages. Now, pagkatapos ng stages, pag nag-stage C na yung patient, then we will use the classification of the heart failure. Wait lang, let me open it. There's the classes of the heart failure. So, sa classes, this one, ito yung classes. Ito ginagamit natin kapag ka nag-stage C na yung ating patient. So, class 1, if there is no limitation sa physical activity, ordinary physical activity does not cause signs and symptoms like fatigue, palpitation, or even difficulty sa paghinga. Sa class 2, meron ng limitation, a slight limitation on physical activity. At rest, okay lang yung patient, pero kapag maggagawa na siya ng mga ordinary activities na ginagawa niya, it may result to signs and symptoms of the heart failure. And then pag class 3 na yung ating patient, there is a really marked limitation of the physical activity. So still comfortable at rest, but less than ordinary activity will now result to signs and symptoms. And lastly, ito yung even at rest, the patient may exhibit signs and symptoms. Nahihirapan huminga kahit walang ginagawa. So ito yung mga classes natin. I presented that one because this is included in the algorithm of our heart failure. Wait lang ha. So these are examples of our algorithm na pwede natin gamitin for our patient. Starting with this one, ito patient with LVEF. LVEF is a left ventricular ejection fraction na rate. So this is less than or equal to 40% and then there are symptoms for the patient. Yung tinitest kasi nila yung ejection fraction ng heart, that should be 50% kasi dapat. And then, syempre, nag-lower pa sa 40%. So, ano yung ginagamit natin here for our treatment? Triple therapy with ACE inhibitor, or if the patient cannot tolerate the dry cough, then we may use ARBs. Okay? And then we may use the following also, the BBs and the MRA. And then, after giving the drug, we have to reassess symptoms and then we may classify them according to the classes, no? Kung class 1 pa rin siya, just continue with the triple therapy. Pero if the patient is classified either sa 2 to 4 na classes, depending on the symptoms, like just this one, yung mga heart rate, i-check yan siya. So, depending kung anong class siya and symptoms, pwede tayong mag-add ng Ivabradine, or pwede nating i-switch ang ACE inhibitor or yung ARBs to ARNI. ARNI is an angiotensin 2 receptor blocker, neprilysin inhibitor like sacubitril and our valsartan na combination. Pero kung grabe na talaga yung symptoms ng ating patient, baliktad, bradycardia siya. I mean, not really bradycardia, but it's less than 70 beats per minute yung kanyang heart rate. We may switch the ACE or ARBs to ARNI also, but this is just for eligible patients. So, walang Ivabradine dyan. And then, after that, syempre, there is monitoring and then we will be reassessing the symptoms of our patient and then we will be looking into the ejection fraction. If NYH 1 or class 1 pa rin siya with LVEF na more than 35%, just continue with the treatment and then reassess after 1 to 3 years. Okay? Tapos, kung NYHI 1 to 3 and then less than 35% yung class 1 to 3 tapos less than 35% yung ejection fraction, we may use the ICD-CRT algorithm na yung gagamit na tayo ng mga defib na mga pwedeng ilagay sa heart to help the heart na mag-pump. Okay, so hindi na siya like for treatment. Pag class 4, we may consider additional drugs like our vasodilators, hydralazine, and our nitrates. And then, pwede na natin i-refer yung patient natin for advanced heart failure therapy. Yung parehas sa ICD-CRT, yung mga mechanical circulatory support or yung mga transplant. And palliative care, referral. So, syempre, there is still reassessment here. Okay, after giving the treatment. So, this is an example of an algorithm that we may use for our patient with heart failure. Okay? So, yan yan. I'll be sharing this with you sa inyo. I-post ko na lang din sa Google Classroom ha. Though you may access this one in the internet, pero para mas madali, ipopost ko na lang din. Okay? So, if you are going to answer the posted na mga case studies, pwede niyo siyang gamitin para sa resolution, para sa plan ninyo ng treatment for the patient. So, any question? It's 5:30 ha, 6:30 yung ating klase, no? Wala. Sino kayo next na magre-report? Si Sir Andrada, no?
Yes, ma'am. Ako po.
Haba ba ang report mo?
Hindi naman po, ma'am. Pero may supplementing videos po kasi ako, ma'am.
Ah, can we start tapos kung hindi man matapos, so just continue next meeting. Okay lang yan?
Okay naman po, ma'am.
Okay. But before that, can we have 5 minutes na CR break, water break first? Tapos mag-continue tayo.
Okay, ma'am.
Okay. Are we all here? Kindly react if you're already here so that we can start. Okay? Sige. So, dito na yung iba. Let us start. Sir, you may start now with your presentation.
Thank you, Doc. So good afternoon, guys. Doc, good afternoon. So yeah, I'll be discussing about cardiac arrhythmia. This is just a simplified version from the Lippincott book, since I think Doc will also give some supplementals with regards to some drugs regarding cardiac arrhythmia. So, so what is cardiac arrhythmia? Cardiac arrhythmia refers to any abnormality in the rhythm of the heart's electrical system, which controls the heartbeat. Normally, the heart beats in a regular, coordinated pattern to pump blood effectively throughout the body. However, in arrhythmia, this rhythm may be too fast, too slow, or irregular, disrupting the heart's ability to pump blood effectively. So, usually, the three types of arrhythmia are being too fast, too slow, or irregular. We can call this as tachyarrhythmia, um, bradyarrhythmia, and the last one is fibrillation, or irregular rhythm of the heart. So yeah, these are the five cardiac elements which affects the rhythm of the heart. So we have the sinoatrial or SA node, atrioventricular or AV node, bundle of His, there's the blue one, bundle of branches, and the Purkinje fibers. So as illustrated on the right side of the screen, so you can see the green one is the SA node, which the impulse will be coming from. Then it will be transmitted to the AV node, which is the blue one in here. There will be a gap from the SA node and the AV node, which you can see later sa ECG or sa PQRS na rhythm, na meron pong sa Q part, meron pong decline ng impulse in there. So I'll be discussing it also. Then after the AV node, it will travel in the bundle of His, then bundle of branches, tapos po sa Purkinje fibers. So um, on the next slide, so the SA node, the electric impulse from the SA node is usually represented by the P wave in here. So the P wave, as the electric impulse is coming from the SA node, the atrium, both left and right, will be contracted, pumping the blood from the atrium to the ventricles. Then, like yeah, illustrated in here, once na mag ano po ito, mag emit ng electric impulse, yung atrial muscles po natin is will contract or depolarize. Pupunta po yung blood dito sa ventricles. So as soon as the impulse has a matawag dito, um, gap, eto po yung representation ng Q wave natin. So this is a preparation for the ventricles to pump blood at mag-contract din po. So dito na po usually may illustration po ako na animated na video regarding this one. So much mas clear po 'yon. So ito po yung basic example ng PQRST na wave rhythm. So with this one, the R is the contraction or depolarization of the ventricles. Then this one, S and T, that's the relaxation again. Then babalik po yan sa P wave. So next, like this one, P wave, dito po, depolarization ng atria. Then sa QRS, sorry hindi po kita yung R. Dito na po magdi-depolarize yung ventricles natin, which makes it contract hanggang S wave na po. Then pag repolarize, magre-relax po yung heart. Yan na po yung T wave. So paulit-ulit lang po as the heart continues to pump. So yeah, just brief discussion with the cardiac muscles, because we could actually divide the muscles into what you call this, types, which is their contractile cells or tissues sa muscles. Ito po yung usual na muscles na nasa walls ng atrium or and ventricles natin. So as soon ito po yung nag-help na mag-contract sa heart. Tapos yung cardiac conducting cells po natin, ito po yung electric impulse, which is in charge naman po sa rhythm ng heart natin. So sa conduction and contracting ng cells, meron po tayong tawag dito, action potential po dyan. So I could um, change my screen. Papakita ko po sa inyo yung ano, yung video. Ay, so audible naman po ba yung ano, yung video?
Wala pa. Sige daw. Wala ako naririnig. Ako lang ba?
Ay, change ko lang po yung ma'am yung screen. Sandali. Naririnig po ba ma'am?
Wala.
Hindi talaga ma'am.
Wala.
Okay,
Wala. Wala sound.
sandali.
Ako lang ba? Or baka ako lang?
Oh, wala
Ah,
po siya, Sir Chester.
wala talaga.
Sige po, sandali. Entire screen. Ito po ma'am. Naririnig po ba?
Wala. Bakit?
Sige na lang ma'am. I-share ko na lang po siguro ma'am sa ano, sa group yung
Sige.
video.
Sige, go.
Opo. So sa action potential po kasi as discussed sana sa video, nandun po yung sodium, potassium at calcium, what you call this, ions. Tapos po yung may changes po nung intracellular membrane dun sa video, which creates po nung impulse tsaka yung muscular contraction. So yes, i-upload ko na lang po sa ano, sa room siguro, sa Google Classroom or sa group chat. Sisend ko na lang po yung link. And so let's go on sa next. So the usual the normal heart rate of um the heart is 60 to 100 beats per minute. So arrhythmia are usually classified as bradyarrhythmia, tachyarrhythmia, or atrial and ventricular fibrillation. So arrhythmia, with the word brady, which means lower or less than normal. arrhythmia will be greater than 60 to 100 beats per minute, and the atrial fibrillation is the rapid or and irregular impulse in the upper chambers or the lower chambers of the heart. So, basic mechanism ng tachyarrhythmia so that we could understand more sa mga antiarrhythmic drugs natin. So, mas maganda sana kung makita po natin yung video na may audio, kasi ma-explain po do'n yung mga certain drugs at the same time yung side effects rin ng mga medication. But anyway, so sa tachyarrhythmia, we have abnormal or enhanced automaticity. It is the abnormal sodium permeability, which makes the cardiac impulse much faster than the SA node. Then the trigger activity is the leakage of ions or a premature action potential. So trigger activity, abnormal enhancement automaticity po, usually ito po yung hindi pa po re-release nung impulse yung SA node, pero nagsa-start na po mag-contract nung tawag dito, nung AV node hanggang sa bundle of branches tsaka sa Purkinje fibers. So eto naman po, leakage ng ions, premature or potential action potentials po. Um, and the re-entry, example of which is the Wolff-Parkinson-White syndrome, which usually the normal rhythm of the heart is from the SA node, AV node, then the bundle of his, bundle of branches, and the Purkinje fibers. Tapos magsa-stop na po doon yung impulse, tapos mag-generate naman po ng bagong impulse si SA node. Pero sa Wolff-Parkinson-White syndrome, continuous po yung mula sa Purkinje fibers, pupunta naman po yung impulse sa AV node kahit hindi pa po nagsisignal yung SA node. Tapos paulit-ulit na po yun. So, it causes irregularities or irregular impulse or beating of the heart. So next, so yeah, let's go to antiarrhythmic drugs as classified by Von Williams. So we have class one or class one antiarrhythmic drugs, which blocks the sodium, which increases the phase zero. Sa diagram po, if makita nyo na po, truly understand nyo po ito. So, it blocks the sodium, which decreases the rise in the phase zero and slows conduction of velocity. So we have different um, types or classes of class 1 drugs. We have the class 1A, which nandito po yung procainamide, quinidine, disopyramide, pyramide. Sa class 1B po, nandito po yung lidocaine and mexiletine. Class 1C drugs, dito po yung flakinide and propafenone. So usually this class 1 antiarrhythmic drugs under sa Von Williams classification. Take note lang po yung mga drugs na po ito should be used cautiously since this medication can cause arrhythmia themselves as well. So usually less po itong ginagamit sa clinical setup. So sa class 2 classification, dito po is usually ito po yung mga beta blockers natin. So the class 2 drugs acts on beta 1 receptors in the heart, which prevents the release of catecholamines, decreases heart rate and contractility. So examples of which are propanolol, metoprolol, atenolol, and esmolol. So in the clinical, usually esmolol is given IV. due to its faster mode of action, faster mode of action. So usually in IV po siya. So next, class 3, it blocks potassium channels, which lead to the increased duration of action potentials and refractory period. So examples of which is amiodarone, dronedarone, satolol, dofetil- dofetilide, and ibutilide. So also this one, pinuputol. Usually this one causes arrhythmia themselves again, pero take note po tayo sa amiodarone since it contains iodine. One of the side effects po is hyperthyroidism, at the same time blue-gray discoloration as well. And next is the class 3 classification, or the calcium channel blockers in the SA and AV node. So examples of which are verapamil, diltiazem, which are the non-dihydropyridine calcium channel blockers. So this is commonly used for supraventricular tachycardia and atrial fibrillations. Then other classifications, aside from the Van Williams, is this three that is commonly used as antiarrhythmic drugs. So first we have the digoxin, which inhibits the sodium potassium pump by binding to the potassium site. So makikita nyo po yun mamaya sa video na ibablock niya po yung entry ng potassium site, which increases the sodium ion sa intracellular cell ng cardiac muscles. So, which triggers the increase intracellular, ito po, which triggers to the opening of the sodium-calcium exchange to pump the sodium out and the calcium in. So, this medication also increases the contractility rate of the heart, not only the corrects the rhythm as well. So adenosine, this one stimulates A1 receptors, and it has a short duration of action, which is usually given IV. And the last one is, oh, sorry, magnesium sulfate, is for the treatment of digoxin-induced arrhythmia. It's usually given IV, and upon checking po sa Lippincott, hindi po nila ma-determine kung ano pong exact MOA ng magnesium sulfate. So far, yun lang po ma'am yung report ko, and isasend ko na lang po yung video. It's around mga 20 minutes yata yung video.
Okay, sige. Thank you. Thank you, sir. Kindly send na lang sa kanila yung video para ma-review sa arrhythmia and then paano yung action potential. And then I
Yes,
hope
ma'am.
na-review din natin yung classes of our anti-arrhythmic drugs. So yung class 1 natin are all calcium blockers. Yung class 2 natin yung mga beta blockers natin. Class 3 the potassium channel blockers, and then yung class 4 natin yung mga calcium channel blockers natin. Yun yung ibibigay ko sa inyo na case study for today, and then continuation yan siya sa next na week, guys. Asynchronous man. So, hindi na ako nagbibigay ng new activities sa async na week. Continuation na lang siya balik. Kasi kung magbibigay pa ako para ang dami na talaga. So, i-continue na lang siya gawa. Ipo-post ko later. Now, yung algorithm, meron din tayong algorithm for our for our arrhythmia. Pero syempre, I believe na mention din ni Sir no na we have different types of arrhythmia. So basically, marami din tayong available algorithms for that. But let me just show you an example na pwede natin gamitin for our patients therapy. Wait, let me open it first. Anything that oh wait, saan ko yun nilagay? I forgot. Treatment heart failure, arrhythmia. Oh, wait lang.
Hi ma'am, excuse me po.
Yes.
Puwede po akong mag-post na sa, Google Classroom po
Yeah,
natin?
sa stream, you can do that.
Sige po, thank you.
So, this one is an example na pwede nating gamitin. Now, this one is like for emergency cases, no emergency treatment, like yung patient natin has like yung arrhythmia na kung titingnan natin here may require medication only, but yung mga unstable ones, syempre hindi kaya ng ating ordinary treatment. So, the first thing to do is to identify cause, but syempre we don't need and we don't really delay treatment. Okay? So, i-maintain na natin yung oxygen saturation more than 94%. If stable, pwede tayong magbigay ng ating drugs. It can be IV or IO. Pwedeng adenosine na 6 milligram na bolus, and then pwedeng magbigay ng second dose of our adenosine. If hindi effective ang adenosine, then we may utilize other antiarrhythmic drugs like procainamide or amiodarone. Okay? And pwede tayo mag-consider ng antiarrhythmic na infusion. If unstable yung ating patient, so pwedeng merong hypotension, mag-decrease ng LOC, or magkakaroon siya ng shock or mag-experience ng chest pain yung ating patient, then we may consider synchronized cardioversion. So, nakadepende kung ilang joules. Depende sa QRS ng ating patient. So, makikita natin yan syempre sa ECG. So, this algorithm may be used during emergency cases. Kasi kung nakikita natin here, IV or IO yung ibibigay na drug if the patient is stable. But if not, syempre we have here synchronized cardioversion. However, we have rules na ginagamit ng ating mga physicians for this one sa cardioversion. Okay, anyway, sa pharma, again, we have adenosine here, and then the use of other drugs like procainamide and amiodarone if not effective yung unang binigay na drug. Okay, so this is an example of an algorithm for our cardiac arrhythmia. Okay, do you have questions or clarifications? If ever in practice you encounter na syempre tinatanong tayo what can we recommend, we may syempre the books, yung ating mga pharmacology books kasi uh, magdi-discuss ng pathophysio ng sakit, and then ililist yung mga drugs, and then syempre i-discuss yung mechanism of action and everything about the drugs. But in therapy, we may consider using algorithm, may mga review of literatures sila on yung mga medication na nire-recommend nila, paano siya gamitin, kailan siya gagamitin. We may utilize them. Okay? So again, I'll be posting those, and you may utilize those in your practice or sa mga case study natin. Now, before we'll end, let me show you again. On March 16, we have here drugs for coagulation disorders and drugs for dyslipidemia. Have that on March 16. Do you know when is the midterm exam? I don't have a calendar kasi. Oops, wala. Do-
Sa March 16 daw, ma'am,
March
ang
16. Exam is
Pasko.
sa March 16?
Yes daw. Pero tentative pa daw, ma'am,
Ah, okay.
May
kasi may
Pasko po.
may class observation po daw ng Pasko online.
Ah, okay. So, if ever mag-push through yung March 16 na exam, then we will have the exam. Yung ating coverage lang is yung hypertension and heart failure and cardiac arrhythmia, as well as the introduction I discussed last meeting. So, yan yung magiging coverage. But if ever hindi, kasi may paasko nga, we will push through with the reporting sa coagulation disorders and dyslipidemia. Yun na lang yung gagawin natin. Okay? I hope that is clear. Anything else that you want to clarify before we'll end our session this evening na? Kaya alas 6 na. Wala. Wala na, sure na. Let me stop the recording now.